of three, you're going to start. 1, 2, 3. We are live.
Hello, everyone. A very good evening to one and all. On behalf of Women in Nephrology Win India, I welcome everyone to yet another online webinar on Win India Joint Venture Series. And this is the second such session. I'm Dr. Priya John, consultant nephrologist from AIG Hospitals, Hyderabad, and I'm your host for today's session. This webinar is organized by Win India Group in collaboration with Endocrinology Society of India. And we have two panel discussions scheduled for today's evening session. Before we start off, I invite Dr. Rakesh, who is President, Endocrinology Society of India, to address the session.
Yeah, so good evening to all. Thank you. It's a pleasure having this joint session of the Endocrine Society of India. It's the Endocrine Society of India with the Win India, which is the Women in Nephrology group. So I think it's a pleasure having this session, and we have we also from our society had the Women in Endocrinology having their meeting last week, which was a very successfully conducted meeting with Dr. Shaila, and all the others who are here have been part of that meeting, and so I welcome them all for this joint session with Women in Nephrology. So with these few words, I would like to welcome all of you for this interesting program which is lined ahead. Thank you.
Thank you, Dr. Rakesh Sahai, for your kind words. Now, may I invite Dr. Shaila, who is endocrinologist from Mumbai, to say a few words, and who is a key person in gathering all the endocrinologists on the platform for today's session.
Thanks, Priya. Actually, it's such a pleasure having a joint meeting with the nephrologists, because I think that is the need of the hour. It's we all need to increasingly understand that in medicine, we cannot afford to look at our patients with an absolute microscopic viewpoint. And meetings like this help us understand from each other, enhance our knowledge together to be able to give better health for our patients. So I think this is the way forward. And I'm looking forward to many more meetings with you all fantastic nephros. I've seen a very, very vibrant group over here, and I know it's going to be a great 2 hours of learning. So thank you very much, and thanks everybody for joining in, and everybody who's on this panel. You're all are going to look forward to hearing from them. Thank you very much.
Thank you, Dr. Shaila. So without further ado, we'll start off our sessions for today's evening session. So we'll start with the first session, which is on approach to early diabetic kidney disease. And for this, may I invite Dr. Pia Balani Thakkar, who is a consultant endocrinologist from Bombay Hospital, to invite the panelists and moderate the session.
Thank you so much, Dr. Priya. I'd like to say thank you to our ESI president, Dr. Rakesh Sahai, and Shaila, I think, whose one big kind of passion is to get women together. Shaila, kudos to you for that, to get the women nephros and women endos today on this panel. Like we're all aware, just jumping right in, type 2 diabetes, some of the most serious complications represent heart disease and kidney disease. They represent the greatest pandemic of chronic disease in the world today. 20 to 40% of all patients with type 2 diabetes develop CKD. This gives a great amount of disease burden, financial burden to the patient, a quality of life impact that is unimaginable. We today have the markers to diagnose CKD early. We have therapeutic agents to manage things early, but all of these are still underutilized, probably due to so many doubts that all of us have in clinic in our day-to-day practices. So today, here we have today a star-studded panel, a special panel, all women, endos, nephros in partnership to answer our questions, give us in a crisp, succinct style some take-home pearls, and to improve our knowledge with regards to just simple things, how to diagnose, what kind of diets, protein restriction, biopsy indications, treatment suggestions. Everything today is coming from our panel over here today. So jumping right in, let me introduce to us, to everybody here, our first panel. Can we move on ahead, please? Here we have Dr. Gagan Priya. She's one of the coordinators also for this event. She's a senior consultant endocrinologist at Fortis and Ivy Hospitals in Mohali. So many awards, I can't go through. Scope Certified IJA Award for Best Reviewer, Best Articles, the Professor MMS Ahuja Award, a fellowship in Asia Pacific Pediatric Endocrine Society. Like you're seeing, she's been the co-editor of multiple books, multiple publications, and the founder of Flame. She's the Indian ambassador to diabetes. Let's go on to our next panelist, please. Dr. Varsha Jagdap, who's also an MD, DM in endocrinology with multiple national international publications, the Dr. Palekar Prize, the late Prabhakar Ramdas Adhali Prize Gold Medal. She's been the best resident, has had best paper awards at ESACON, no easy task at all, multiple talks involved in huge community outreach programs. Welcome, Dr. Jagdap. We then have, of course, Dr. Dina Shrestha. She's a senior consultant endocrinologist, all the way coming to us from Nepal. She's the president of SAFES, the immediate past president of DEAN, the founder of DRRC. She's on the JCEM editorial board and the chief editor for the National Consensus Statement of Type 2 Diabetes and Hypothyroidism. She's currently at the Norvik International Hospital at Kathmandu, Nepal, with multiple publications and deep interest in thyroid and diabetes in pregnancy. Dr. Dina, thank you so much for joining us all the way from Nepal. And then we have Dr. Manisha Sahai. She's the professor and head of nephrology, Osmania Medical College in Hyderabad, the editor-in-chief of the Indian Journal of Transplantation, the deputy chair and CME committee of the International Society of Nephrology, and the president of the Hyderabad Nephrology Forum. She's also the VP of WIN, and that's why we're so happy to have her here. She's the executive committee member of the ISO also as well, the vice president of the Indian Society of Nephrology, and again, chairman of the South Asia Regional Board from 2019 to 21, multiple medals, publications, and guest lectures. Welcome, Dr. Sahai, to our panel today. And finally, Dr. Srilata, who's the professor and head of the Department of Nephrology at Government Medical College at Kozhikode, Kerala. Again, major achievements involve Tanker Awards for the Best Young Investigator in Nephro in 2003, a Best Teacher Award, Best Paper Awards, multiple, a Fellow of the Indian Society of Nephrology, American Society of Nephrology, and the Royal College of Physicians. Welcome, Dr. Srilata. All right. And with that introduction, let's all deep dive right into our topic today. And I think we have a list of questions that we've gotten ready that we think would be hard-hitting in terms of the knowledge we want to get from this panel. So Dr. Dina, you as our guest from abroad, we're going to deep dive in with the first question right over to you. So Dr. Dina, like we're seeing today, diabetes comes with so many different presentations. Not all patients with diabetes are going to present with DKD. What is it that determines, which factors are the ones that determine the onset and progression of DKD? And are women like us more at risk?
Thank you so much. And really, this is a fantastic forum for me to talk, and I'm privileged. Thank you, Dr. Sheila, and all the organizers. I think that we do know that a lot of, like you said, the burden of DKD is high, but not all patients get it. So I will answer the second question first. Are women with diabetes at greater risk or equal to men? So according to the studies, actually women are more likely to get chronic kidney disease. But actually those patients, if you see, when it comes to men and women, men tend to get kidney failure. So that is the difference in the incidence of DKD. So women tend to, and what they have seen is that the risk why women get is maybe because of the urinary tract infection, sometimes pregnancy also because of eclampsia. Those are the reasons why women do tend to are more likely to have a chronic kidney disease actually. But men tend to get heart failure. So if you actually see the risk factors that there's a Canadian risk calculator that are actually being used nowadays. And if you see the risk factor for that is actually men. So if you want to calculate kidney failure, men are getting it. And that can also be attributed to sometimes they are thinking that maybe because of prostate, because men do get it. And it seems that testosterone also might not be the best thing for the kidney health. So there are speculations that testosterone might be responsible for kidney failure. So that is the thing that women versus men. And when it comes to factors determining, the risk factors are obviously diabetes. And when it comes to diabetes, it's also like, how long have you had the diabetes? Do you have a family history of kidney disease? How long has the diabetes been there? And about the ABC, it's obviously about not only diabetes, whether your blood pressure, your cholesterol are under control. And I think there are other risk factors in our communities also, sometimes alternative medicine. I would want to put that in, that sometimes people are taking some supplements, herbal medications, which we don't know much about. And that might be another reason or a risk factor that we can put in our society as for patients who are developing DKD. Then definitely obesity and smoking and older age. And there's also been enough studies to show that ethnicity, sometimes the minor ethnic people might be susceptible to DKD more than others. And I think if I have to list others other than blood pressure, then there was also about low birth weight. So patients who are born with low birth weight, we know a lot about fetal programming, and thanks to India doing a lot of research on that a lot of things also is about fetal programming. So that also might make the patients more susceptible to having kidney disease. But
so
we have
just a quick thing with regards to Nepal. Would you say the incidence and prevalence of DKD there is as much as we see it in India? I mean, ultimately, we are all part of the subcontinent, so to speak. So would you say that it's pretty much similar as the numbers we see here?
I mean, it's not uncommon here, and we do see now as our diagnoses are getting better, we are checking urinary and albumin creatinine ratio. We're not waiting for symptoms. Definitely, we see that the burden is high. Like, unlike foot disease, like I think India has a lot of foot ulcers and diabetic foot, which Nepal almost doesn't see. But I think for CKD, yeah, it's pretty much
the same. All right. So thank you so much for that. Dr. Gagan, my next question goes out to you. Are we over here missing the window for early diagnosis of CKD? Screening, we know the guidelines recommend it, we know about it, we read about it, but it's not happening. What are the implications and how can we avoid this situation?
Thanks, Dr. Pia. Taking forward from what Dr. Deena was saying, I think as diabetes care providers, we want the best case scenario for people with diabetes. And the best case scenario would be if we can prevent the onset of diabetic kidney disease altogether. But I think there are too many factors we don't understand. We now understand that glycemic control is probably not the only factor. Hypertension control is not the only factor. So what guidelines have recommended and what evidence has shown that if we can catch these patients early on, in the early stages, in the stage of hyperfiltration or microalbuminuria, and then stage 2, 3 CKD, we can prevent the progression. And yes, we have therapies for that. We will discuss it as the panel goes along. But despite guidelines clearly recommending it, and almost every guideline has this universal recommendation that any person with type 2 diabetes should be screened right in the beginning of diagnosis, because we don't really know how much of disease burden has already gone through. And we also know that even in pre-diabetes, these pathophysiological processes are starting. When it comes to type 1 diabetes, diagnosis should, again, the screening should begin either at diagnosis or, if it's a child, then at least within 5 years of the diagnosis. However, what is important to remember is that most diabetes care in our countries is being provided by the primary care physicians. And there's a lack of awareness and inertia at that level. Probably they're overwhelmed by too many factors to take care of. So they're dealing with a lot of patients. And also there is lack of awareness at the public level. So a patient with diabetes, if you look at data from Chennai, people with diabetes are not really aware that it can cause complications or what are the complications that can occur. So almost 1/3 of the patients lack that awareness. So these are possibly the reasons why, we have this kind of inertia in screening. And the problem that ends up is the alarm bells go off when the patient has already reached stage 4 and 5, and then they are running to the nephrologist. And honestly, it's too late by then. Yes, we can do something at that stage also, but it is already late. So what can be done is increase awareness at both the clinician and the public, the primary levels, grassroots levels. And screening strategies have already been simplified, so measuring EGFR and albumin. And now even a dipstick test in the early stages can suffice. Now, what are the implications? We have to understand that now diabetes is occurring at a younger and younger age group. So it's not uncommon to see 20 plus coming with type 2 diabetes diagnosis. And projecting forward, when these patients are going to reach the middle age or, the transition of 40s, 50s, 60s, we're going to see a huge and exponential rise in CKD cases, which we've already seen. Diabetes has become the #1 cause of chronic kidney disease in India also. But projecting forward another 1 to 2 decades, possibly it's a volcano that's about to erupt.
Right. Very, very eye-opening over there. So leading from Dr. Gagan's information over here, I'm going to pose our next question to Dr. Manisha with regards to solutions with the same problem. Dr. Manisha, what do you think should be the markers that we as endocrinologists or our general physicians at the grassroots level, like Dr. Gagan has mentioned, what should be the early markers and indicators of CKD? How do we identify it? We spoke about dipstick. Dr. Gagan just spoke about dipstick. Is that something that we all should be doing in our clinics also as well? How do we ensure, again, practically speaking, that routine screening is implemented in all of our clinics for all of us doctors who are seeing diabetes patients?
So thank you, Dr. Priya, for that very pertinent question. So before I answer your question, as a nephrologist, I would just like to tell you, you'll be surprised to know how many patients end up with end-stage kidney disease needing dialysis every year in India. It's 2 lakh every year, greater than the population of many of the countries. And I'm not talking about CKD. CKD is around 1 crore, but 2 lakh every year end up on dialysis or need a transplant every year. And how many of these are diabetics? Almost 40 to 50% of this population is diabetics. And sadly, people know about diabetes, they may know about hypertension, but CKD, kidney problem, people are blissfully unaware. And CKD affects around 1 in 8 of Indian population. So CKD is quite common, almost as common as diabetes. However, people do not know about it. And I'm not only talking about the general public, even the general practitioners and many of the other specialty doctors. So they forget that the management of diabetes does not only involve blood sugar control. So it's very important that all of us, whatever be our specialty, should have a high index of suspicion for kidney disease and diabetic. Now, your question was that how do we screen? What are the early markers? So remember that diabetic nephropathy can be completely asymptomatic till the very last stage when the patient comes with decreased urine output or with puffiness and edema. By that time, damage has already been done. As Dr. Gagan said, you cannot reverse it at that stage. You need to pick it up early. The diabetic kidney failure passes through certain stages, maybe not in type 2 diabetes, but still you have a window of opportunity. So the day a person of type 2 diabetes comes to you, that is the point you start screening for nephropathy from day 1 in type 2 diabetes, and type 1 diabetes generally 5 years after onset. And what are the screening tests? Very simple: urine protein and creatinine. With creatinine, you can calculate the EGFR. Unfortunately, people think GFR as per the biochemistry and physiology class is a horrible formula and nobody wants to do it. But we should be all aware, we are all smart nephrologists, smart endos, smart doctors. We have a smartphone and you have a free GFR calculator from NKF. So just type their GFR calculator and lo and behold, you have the screen in front of you. You have to put only the age of the patient, the creatinine value, the sex, male, female, and you have to put the race. That's it. And you have a value of creatinine. So this, I request everyone, forget about molecular markers, advanced biomarkers, at least have a GFR on your prescription, whether you are an endocrinologist or a nephrologist or a physician or MBBS doctor or even an Ayush worker. Because we have 2,500 nephros in India, we are a population of 1.3 billion people. We have around 10 lakhs Ayush doctors and around 7 lakhs, roughly, we have MBBS doctors. All of us have to do this screening. So on your prescription in a diabetic patient, please have the GFR mentioned. And if you don't want to do it, at least ask your lab. They'll calculate and do it for you. So GFR should be there on your prescription and urine protein. Now, whether you do a urine albumin or whether you do a urine protein, because many people say we don't have urine albumin available and all that, do a protein. If you're not able to quantify it, do a dipstick at least. So urine protein and GFR, these are the two important early markers. Apart from that, if you look at the clinical markers, family history of diabetic nephropathy is important. One parent diabetic nephropathy, 25% risk that you might be having in the patient. Both parents, around 60% risk that the patient may have diabetic nephropathy. So always ask for family history of diabetic nephropathy, look for hypertension in that patient. And then now recently we have clusters being defined in diabetes as well. So some clusters are more prone to diabetic nephropathy. For instance, we have a cluster in diabetes described by Anjana Mohan and also in the India-Diab study where it was shown that those who have a combination of insulin deficiency as well as insulin resistance, that cluster is very prone to develop microvascular complications, both nephropathy as well as retinopathy. But that needs to be validated in further studies. But remember, I would just like to end by saying it is asymptomatic, can be asymptomatic, and you have to screen. That's the first step. The later on talk comes later. There are so many tools to prevent the progression, but what will you prevent if you are not able to diagnose it? And this diagnosis should be done at ground root level, at general physician. And I think this is a forum which increase the awareness. And that's the reason the theme of this year is increased awareness, bridge the gap. The World Kidney Day is increased awareness, bridge the gap. So I hope that answers your question. And newer biomarkers, I leave it to Dr. Srilata. She would be telling all about the newer biomarkers.
So Dr. Manisha, before I let you go on this answer, one quick question in just a number. What percentage of these patients are landing up with getting a transplant? You mentioned the numbers who are landing up with advanced kidney failure. How many are actually managing to get a transplant in our country?
Excellent question. So I told you 2 lakh, right?
Yes.
Out of that, India is doing how many transplants per year? Just petty 10,000, 10 to 12,000. And why is it so? 90% of these transplants are living transplants. Just 10% are deceased donor transplants. Living transplants are low in number because many of the times the donors are either parents or spouses. Many of them are diabetics themselves. So that is also a big problem. And nowadays the living relatives don't want to donate. They put the patient on the cadaver list most of the times. And unfortunately, the first question you asked about the difference in males and females, here there is a big difference. Most of the donors are females, 90%, and recipients only 90% are males. So 90% recipients are males, 90% donors females, and out of those female donors, spouse is the default donor, if I can use the term. So the number is just 10,000.
Right, and that's what. And one more last, if you could answer in one little word for me. The formula you mentioned for calculating of the GFR, is it the Cockcroft-Gault that you are typing into? Which is it that you would recommend for our audience today?
Absolutely wonderful question. So as I said, that NKF calculator has all the formulae, not one. The topmost one mentioned is CKD EPI. Use that formula. That's the one which is standard. You have MDRD formula as well. But remember, MDRD is not accurate beyond a GFR of 60. Below 60, it's accurate. But above 60, it just mentions that your GFR is about 60, but doesn't give a number. So the best thing is EPI formula. The only thing is with the EPI formula, the creatinine should be done by IDMS method. But again, even if you are doing it by Jaffe method, you can always convert it. So no problem. It will do it itself. So just click on the CKD EPI and just fill the value. Enough. That's it.
Thank you.
Cockcroft-Gault is generally for dose modification. And nowadays it's not used because it has certain inherent fallacies.
Right. Okay. Thank you so much for that clarification. That's very valuable. So as Dr. Manisha has now turned the forum over to Dr. Srilata to tell us about the newer markers, biomarkers that may help us detect early DKD, and what's the difference really between the GFR and the UACR. Dr. Srilata, please enlighten us.
No, all the new biomarkers are well studied in acute kidney injury, not for CKD. For CKD, it is still, because for cardiology, they have several newer biomarkers implemented from CPKMB to troponins. But since then, for nephrology, it is the creatinine only. And now we have another marker called serum cystatin C. And you have, as Manisha said, CKD EPI formula incorporating cystatin C. The advantage of cystatin C is it is much more, you can detect abnormal kidney function at a better GFR. Your serum creatinine will increase only when GFR decreases to 60 ml per minute, that is 50%. But cystatin C will increase by 80 ml of GFR. So early detection with up to 20 ml of GFR with cystatin C. And you have, at least in research, you have serum uromodulin, which is the TAM phosphoprotein, which is little secreted into the serum. And if you measure, that is a marker of tubulointerstitial function. So that is also another biomarker in this research, which is not applicable to our general practice. For general practice, it is still serum creatinine, serum cystatin C, and urine albumin creatinine ratio. That's all. That is enough for early detection in our setup.
So, Dr. Srilata, do you recommend that all of us doctors also start doing the cystatin C? I'm not sure whether Dr. Gaga and Dr. Deena as endos in their practices are doing this. I know I'm not, but probably this for us is a learning mark. And what is the cost of this test also? Dr.
It is not routinely available for day-to-day practice.
I see.
And only specific situation you can recommend, and it's only 1 or 2 centers in one state may be doing that, not a routine lab.
Not a routine test yet to practice.
Yeah.
Okay, that's interesting to know. Thank you on that. Dr. Varsha, we're moving on to you right now to ask basically what were the traditional approaches for prevention of onset and progression of CKD? And of course, the million-dollar question, is there any role for protein restriction? When, how much, all of that? Please tell us.
Yes, thank you, Priya, for the question. And I must say that we are learning a lot, and it's been an interesting discussion so far. So coming to my question, so when it comes to the traditional risk factors, as Dr. Deena has already highlighted, we would like to keep the HbA1c below 7. We would like to keep the office blood pressure readings below 130/80, keep our lipid profile within control, both the total cholesterol, LDL, as well as the triglycerides. So these are all the traditional things that we would do. We would also want our obese persons to lose weight. We'll advise them about smoking cessation. And the RAS blockade with ACE ARBs, we all know that they are able to prevent the progression. Now, coming to the controversial part, actually, about the protein restriction. So when I was reading, so I came across that, that when the eGFR is more than 60, then it's protein restriction is actually not required. And if you actually think about it in Indian context, then many of our Indians actually don't take the 1 milligram, but what has been advised, we would be taking somewhere around 0.7, 0.8, which is already on the lower side. So in that context, I think it is not really required when the eGFR is more than 60. But yes, in the stage 3, 4, 5 CKD, even the non-dialyzed ones, it has been recommended that the protein restriction should be there, and around the ADA recommends 0.8 to 1. The KDOK guidelines say around 0.7, 0.6 to 0.8. So there is certain differences amongst the two. But roughly the protein restriction is lesser in a diabetic variety of CKD versus a non-diabetic variety of CKD. And it is quite a controversial area. There are, papers saying that even in spite of protein restriction, you can actually sometimes cause protein malnourishment in a end stage CKD, or in the later stages. So that has to be balanced. And I think here comes the role of a nutritionist, where they modify the amount, not just the quantity of proteins, also the quality of proteins is important. That what kind of protein is the patient taking, and whether the essential amino acids all are going into the patient. So that also matters. There is also an interesting bit about differences between a vegetarian protein and a non-veg protein sources. And it has been, there are studies which have said that replacing maybe a non-veg source with a soy protein may actually be helpful. So there are such papers also, but nothing is quite, clear. The grade of recommendation is very low for all these recommendations.
Fair enough. All right. So I'm going to ask Dr. Deena that if we do all of these suggested maybe diets or whatever has been suggested, how effective are these are all these modalities rather to prevent progression of DKD in early stages? At what stage do you call it reversible? At when do you call it irreversible and counsel your patients accordingly maybe? And since we're saying the majority of our patients are coming so late, are we really already missing the boat?
Thank you so much. I think we have Dr. Manisha and the other nephrologists. I'm going to say that my practice is based, my answers are based on maybe my clinical experience, and which we are here to discuss the differences. So that would be interesting. I think that stage 4 and 5, it kind of becomes difficult to reverse. I think then we are thinking about how to stop progression, and how to make a better quality of life. And like Dr. Varsha said, change from, even I have heard that we do that from plant, we try to give plant-based protein. But definitely when it comes to prevention of DKD, when you are in stage 1, 2, or 3, we have seen like in our own practice where you have a protein creatinine ratio of 45 or even 100 plus, and then you tell them to stop smoking, you control their blood pressures, you give them the right ARBs or ACE, and now we have the Armageddon of other GLP-1s and SGLT2. And definitely we do see that not only we are stopping progression, but definitely there's regression. Like we do see that patients are doing better. But I think once they're in the late stages, I see then my aim becomes more like how to stop the progression, how to improve the quality of life, how not to put them into end stage, that becomes my way of treatment. And when it comes to, as you said, they're missing the boat, I really think that that's true, because it has to do a lot with our culture, with the practice. And like Dr. Gagan said, a lot of physicians are looking after them. And it's kind of sad to see that we're still in that stage where, even asking a patient to do an glycosylated hemoglobin is challenging, right? And if they have so to check your microalbumin or, get an ultrasound done, those become difficult. But definitely, sometimes I also use the retina trick. I don't know that if people are getting nephropathy, I do tell them to see the retina. And if they don't have retinopathy, I feel that it's encouraging, and I tell them that, there's still chances that your kidneys will get better, or, because it's not, because the eyes are not affected. So this is something area that we have to discuss. But I've been in private practice, so it does become difficult for patients to, it was interesting to see that, like Dr. Srilata said, the new tests, the markers that are there, but for us, even the basic challenges are difficult. So I guess definitely it would work, and in India also, I'm for sure there's a lot of people having gutka and these things for men, and we know that men are the ones who are progressing to end stage renal disease, but how to make them stop. And then the simplest of all, which is salt intake. Like, how successful are we to tell them to stop having their pickles or chutney, So definitely there are effective modalities, and with SGLT2, GLP-1s, right? And like Dr. Gagan mentioned in this chat, we have the non-steroidal frunenon with the newer things. There's so much scope with good APC controls. Like, of course there is, but we just have to make our patients and our doctors more aware, I think.
Fair enough. Absolutely. Thank you, Dr. Deena. Dr. Manisha, circling back to you, and we love the pearls of wisdom that you're posting for us. So thank you for that. So Dr. Manisha, I'm going to ask you just very quickly about anemia. How early does it occur? How do we, as general, maybe, we aren't all nephrologists over here. At what point, basically, what are the causes? How do we assess it? And alongside with that, I want you to also let us know how early we need to be referring patients to you.
Okay, so that's another pertinent point. Remember, anemia is very common, especially in patients of chronic kidney disease. It occurs generally from stage 3 onwards, we start looking for it. But in diabetic nephropathy, it can occur even earlier, in stage 1 and stage 2 as well. So remember that most of the symptoms which we attribute to CKD may be, in fact, because of anemia, which we have missed because we have not tested for it. So what we should do is, anemia screening is mandatory for all diabetics, especially stage 3. It is required by all guidelines. In diabetic nephropathy, you can do it earlier itself. And what sort of, and why does it occur early in diabetes? So remember that in CKD, anemia occurs because of most important cause in India is still iron deficiency, then B12 deficiency, folate deficiency. Nutritional deficiencies are common. Always look for sources of blood loss to local blood. All those things should be done because they are still common even in a patient of chronic kidney disease with or without diabetes. Apart from that, erythropoietin deficiency is common. So erythropoietin deficiency is not the sole cause. Look for the other nutrient deficiencies as well. So this occurs in any patient of chronic kidney disease. And we all know that erythropoietin deficiency, the anemia is generally normocytic, normochromic. Whereas in iron deficiency, you have hypochromic microcytic anemia, and it's easy to pick up. Just do a hemoglobin, just do a peripheral smear, and you will have an idea what sort of anemia you're having. In addition, in diabetes, there are certain important factors which may contribute to this anemia. And what are these? One thing is many of the diabetic patients may have associated thyroid disorders, which may contribute to it. Many of the drugs used for treatment of diabetes or diabetic nephropathy may be responsible for anemia. Important one is B12 deficiency with metformin. The TZDs, they themselves cause a bit of fluid retention and may cause anemia. In addition, you have RAS blockade in many of the patients of diabetic nephropathy, and they are important causes of anemia. So diabetic nephropathy, this is one of the important causes. In addition, in diabetic nephropathy, it's said that there is some degree of vascular lesions and tubulointerstitial lesions. And there is a thickening of the basement membranes inside the kidney. And we know that the erythropoietin is produced by peritubular fibroblast cells in the kidney. So what happens is that the erythropoietin is generated because it's stimulated by hypoxia. So this hypoxia signal does not reach the erythropoietin producing cells because of the thickening of basement membrane. So that's one mechanism which is responsible for increased incidence and prevalence of anemia in diabetic patients. Another important thing is autonomic neuropathy. So somehow the splanchnic nerves are responsible for this hypoxia-initiated erythropoietin production. And this neuropathy results in decreased response to hypoxia and hence decreased production of erythropoietin. So these are some added mechanisms in patients who have diabetic nephropathy. But having said that, the most important thing is either iron deficiency or erythropoietin deficiency. So my message to all non-nephrologists as well would be, there is no need for referring all the time to a nephrologist for management of anemia. The basic rules and tenets of diagnosis of anemia apply. Do a hemoglobin, do a peripheral smear, look at the type of anemia, do an iron profile as well, which most often we miss. Iron profile consists of serum iron levels, and you look at the ferritin levels and transferrin saturation. Transferrin saturation is nothing but serum iron divided by total iron binding capacity. So even if you don't want to remember all these three parameters, remember maintain a ferritin more than roughly around 200. Nowadays, we can go up to 500, even 800 also, but most of the guidelines around 200, 300 ferritin levels, and maintain a saturation, transferrin saturation level to the tune of 30%. So this shows an adequate iron stores. Another important point we have to remember is I've talked about iron deficiency. So iron deficiency, the true iron deficiency, where the iron in the body is low, you can diagnose by low levels of ferritin and low levels of transferrin saturation. So TSAT will be less than 30 and ferritin may be less than 100. That's true or absolute iron deficiency. Another important type of iron deficiency, which we need to remember in CKD patients and diabetic CKD patients, is functional iron deficiency. Here, you have sufficient iron stores in the body, but they are not used for erythropoiesis. And why does this occur? Because most of these iron stores are located inside the liver cells or reticuloendothelial cells, and they are not available in the blood. Why does this happen? Because the migration of iron from intracellular stores to the blood, it takes place through a protein called ferroportin. And this ferroportin is inhibited by hepcidin. So hepcidin is a bad molecule, ferroportin is a good molecule. And in inflammatory states like diabetic nephropathy and CKD as well, the levels of hepcidin are very high. So despite the iron being there in the body, inside the cells, it's not available for erythropoiesis. So this is called functional iron deficiency. So why I'm telling you about absolute iron deficiency and functional iron deficiency? Because the treatment for absolute iron deficiency would be obviously giving iron. Because iron in the body is itself low. But the treatment of functional iron deficiency is not iron. If you keep on giving iron, you are causing, in fact, iron toxicity, hemosiderosis. So in that case, you have to manage the pro-inflammatory factors. And sometimes here, SGLT2 inhibitors also help. Sometimes in dialysis patients, increasing the dose of dialysis helps. And now we have newer molecules called HIF-PHIs, oral erythropoietins, which are soon to come in the market, which will help in reduction of levels of hepcidin. So they are the newer drugs. So as of now, we treat anemia by giving iron and erythropoietin. Make sure always, as non-nephrologists, before you embark on giving erythropoietin, make sure that the iron deficiency is corrected. Otherwise, it's not going to help. So the patient should be replete in B12, should be replete in iron, and then you embark on erythropoietin therapy. And erythropoietin, so many varieties are available, which could be subsequently discussed. So I hope this answers your question. Anemia is common. Many of the manifestations of CKD are because of anemia. Diabetic anemia, be on the lookout. It can occur in any stage, right from day one. And anemia correction pays rich dividends, retards the progression of CKD, decreases the cardiovascular morbidity and mortality, and improves the quality of life. So maintain a hemoglobin around 11 gram per DL, but do not overshoot. Do not try to give a hemoglobin more than 13. That's not recommended in patients on CKD.
Thank you, Dr. Manisha. That was such a good 101 for us on anemia, a good revision for me also as well. I think we need to have a little more revision from you on just management of anemia again. So moving on to Dr. Srilata. Dr. Srilata, please tell us, how do we manage anemia? As Dr. Manisha has said, when should we consider erythropoietin as part of the therapy?
Before starting erythropoietin, always, as Manisha said, correct iron deficiency. Iron deficiency is one of the most common factor which leads to erythropoietin resistance. So correct iron deficiency, usually we give 1 gram of parenteral iron. After a trial of oral iron for 3 months in CKD, give parenteral iron of 1 gram loading dose, and then see ferritin is more than 500 and transferrin saturation more than 30%. Still hemoglobin is low, less than 11, we start them on erythropoietin. And usually the dose that is given is weekly, once or twice of erythropoietin. And there are different preparations of darbepoietin which requires less frequent administration. And as Manisha said, there is newer oral HIF inhibitors are coming with, which is already marketed in the name of oxemia, which requires only 100 milligram on alternate day. So we continuously give them the erythropoietin, monitoring hemoglobin, and target around 11 to 13 grams.
Thank you so much. That was really crisp and clear. Dr. Gagan, I'm curious to know, do you prescribe erythropoietin in your practice, or are you sending it to the nephros? And then again, the second question for you is SLT2 inhibitors. They're everywhere right now. Please give us your viewpoints.
Yeah, thanks. So I think to some extent, I've been doing erythropoietin and iron therapy at my level, because even the nephrologist in my hospital is overburdened. So sometimes it's just a quick call and can I handle it, and that's it. So I think we need to learn how to manage these patients and also learn when to refer to nephrologists.
Right.
But coming to SGLT2 inhibitors, I think they are a molecule that has changed the dynamic. So at least bridged the gap in CKD management. And until about a decade ago, all we had was RAS blockers. That's the only pharmacological agent that really made an impact. And of course, glycemic control, lipid control, blood pressure management, everything mattered. But with this indirect evidence came, interestingly, from cardiovascular outcome studies of SGLT2 inhibitors. The initial studies were targeting on whether or not they have a cardioprotective potential. But in the secondary outcomes, what was found was that there is a significant renoprotective effect also. Now, the initial studies with empagliflozin, that was EMPA-REG outcome study, then we had the Canvas program with canagliflozin, and we had dapagliflozin study declared TEMI also. All of these studies were relatively patients who were renally healthy, I would say. They had, most of them had normal GFRs. Some of them had microalbuminuria or, not the nephrotic range proteinuria. And what was found was that there was a reduction, a clear reduction of 35 to 40% in renal risk. And what we were talking of was not just albuminuria, but hard renal endpoints, doubling of creatinine, progression to end-stage renal disease or need for replacement therapy or renal death. So that was like phenomenal. There was an initial decline in eGFR, similar to what happens with RAS blockers, but then eventually the GFR stabilized and the GFR decline was slower than the comparator arm. Following the success of these, dedicated renal outcome studies have also been conducted, and some of them have already been published. So we have Credence with canagliflozin, and we have the DAPA-CKD. And very interestingly, 2 days back, the EMPA kidney trial also has been, stopped ahead of time because of positive outcomes. What is seen in these studies is that most of the patients enrolled are patients with proteinuria and CKD. They've gone up to eGFRs of 25 and 30, so lower and lower. Because earlier there was a concern with eGFR that SLT2 inhibitors don't give glucose-lowering properties below 45, so why consider them? But now we have data on patients with eGFRs of 25, 30 and above that it has renal protection, and the same magnitude of benefit is being shown in all of these studies. The trial design also included that even if the eGFR falls below 30, till the need for renal replacement, the drug can be continued. So now we have safety data also to that stage that if a patient is already there on that drug, it can be continued nonetheless till there is a need for renal replacement strategies. Now, how do they work? That's another question. So the effect does not come from its glucose-lowering properties, that's clear. But what has been shown is that in addition to glucoseuria, it is also causing natriuresis. It acts on the sodium-hydrogen exchanger and causes natriuresis. So one of the mechanisms proposed is that it increases solute delivery to the distal tubules sensed by macular densa and thus causes afferent arteriolar vasoconstriction. So your glomerular filtration pressure is reduced. And that's one mechanism. In that aspect, it is similar to what ACE inhibitors and ARBs would offer, but it's acting on the afferent arteriole instead of efferent arteriole. So the effect comes as synergistic and cumulative. But there are several other mechanisms. It seems to be acting also to reduce inflammation and fibrosis. It increases hematocrit. That's one of the important mechanisms that have been shown in mechanistic studies, possibly responsible for cardioprotective and renoprotective effects. Other benefits, possibly endothelial stabilization, direct improvement in myocardial and renal oxygenation. So all of these hypotheses are there.
Right. Thank you. I think SLT2 inhibitors, which we claimed as our drug once upon a time, long time ago, now are pretty much across the board and actually are making us understand that we are all pretty much managing the same cardiovascular, renal, diabetic, like the whole metabolic disease. I think they've unified all of our specialists in a way. So, Dr. Varsha, at your end, other therapies for the same purpose?
Right. So besides SGLT2 inhibitors, we all are aware about the GLP-1 analogs. I mean, so as Dr. Gagan mentioned about the CVOT data, so similar kind of CVOT data done for liraglutide, semaglutide brought about the same points that they are able to reduce the renal composite endpoints, and this was mainly driven by the reduction in the albuminuria. And if we talk about other class of agents, then there are mineral receptor antagonists. So Finrenon. So why Finrenon and why not say maybe a spironolactone? So spironolactone, we know that when you use it with the ASA or ARB, the chances of hyperkalemia go up, and there comes the limitation of using it. So, but with Finrenon, the chances of hyperkalemia are less. And the Fidello-DKD trial has actually showed that it can reduce the albuminuria, it can reduce the progression. And there have been certain other effects also. That means they are able to reduce the hospitalization for heart failure. The all-cause mortality also was shown to be reduced, though not statistically significant, but that was also reduced. So definitely Finrenon, I think, is a new molecule which should all watch out for and should be definitely be an addition to our kitty for the preventing the progression. There are other theoretical, things being talked about, the pentoxyphylline, the endothelin receptor antagonists, and so there are multiple, many factor inhibitors and so on. But I think what practically now that we can all talk about is, besides SLT2 inhibitors, are GLP-1 RAs and Renal.
Thank you for that. Thank you for that. So just, Dr. Deena, at your end, a word on vitamin D, the universal vitamin, and hyperuricemia, another lab that we commonly see amongst our profiles. What is your take on that?
Yeah, thank you so much. So it's 1 minute answers. So I would say definitely if you have a high creatinine, I would want to treat hyperuricemia. Otherwise, without CKD, usually asymptomatic hyperuricemia, we're not treating. Also, we want to make sure that if they are hyperuricemic, and then to tell them that, you know, if they're using NSAIDs, that can further damage the kidney. So I think that is one thing that you want to think about. And what was the other one?
So hyperuricemia and vitamin D.
Okay, so vitamin D, I think the only thing is when it's end stage, we want to give them the active one. Otherwise, we can just supplement them with the 60,000 till your kidneys are good. So
fair
yeah.
Enough. Thank you for that. Dr. Gagan, quick question to you. What would you consider are alternate causes of CKD in people with diabetes? And again, from our perspective, when do you refer to a nephrologist?
Yeah, so I think people with diabetes are not exempt from the other causes of CKD. So we have to think about those simple things like, you know, an upper tract urinary infection, or an obstructive uropathy, or membranous disease, IgA nephropathy. So all of those things, minimal change disease, all of them can occur in a person with diabetes. So when to refer to a nephrologist is when you're having an atypical presentation, such as a rapid decline in EGFR, because a normal diabetic kidney disease EGFR decline may be only around 3 to 4 ml per year, you know, in EGFR. But if there's rapid decline, nephrotic range proteinuria, active urinary sediment is being seen. There's refractory hypertension. Again, you might be thinking of alternate causes. Hematuria can be another cause of concern. Or let's say you've started a patient on RAS blockers, or there's been a severe decline in EGFR. Again, you would be thinking of renal artery stenosis. So these are some of the indicators where I think we would want to refer to a nephro.
Fair enough. Dr. Manisha, for you, biopsy, when do you consider it?
So just to put it in very simple words, we know that diabetic nephropathy is a gradually progressive disease most of the times, with proteinuria, hypertension, and progresses to renal failure. So in case you have nephrotic proteinuria, meaning more than 2 to 3 gram protein loss in urine per day, that's one indication where you think of something other than diabetic nephropathy. The second thing is rapid progression of renal failure, rapidly progressive renal failure. The creatinine is 1 first day. In a week's time or in 2-3 days time, it's jumping to 3, 4, 5. That's not the natural course of diabetic nephropathy. So you need to biopsy. Presence of active urine sediment. And what do you mean by active urine sediment? RBC in urine, dysmorphic RBC in urine, RBC casts, because generally hematuria does not occur in diabetic nephropathy. That's the third indication. The fourth important indication is absence of retinopathy. So they are broad indications. Generally, in type 2 diabetes, you have around 60% association between nephropathy and retinopathy. So it's not 100% thing that if the retinopathy is there, it's always going to be diabetic nephropathy and vice versa. But generally, textbook indication of biopsy is if retinopathy is not there, plan for a biopsy. Then other important thing is short duration of diabetes and you develop renal failure. That's also another indication, especially important in type 1 diabetes, because nephropathy generally does not occur in the first 5 years. So if you have type 1 diabetes going into some renal disease in 2 to 3 years, think of non-diabetic kidney disease and do a biopsy. And the last important indication is any systemic features. You have rash, joint pains, all those things. So think of something else other than diabetic nephropathy. So these are the 6 classical indications when you would refer a person sitting or visiting your clinic where you are treating for diabetes and diabetic nephropathy. These are the red flag signs. The 6 signs, whenever these are present, remember to refer to the nephrologist, because this may be non-diabetic kidney disease and the treatment is different. Thank you.
Okay, thank you, Dr. Manisha. You sound like a textbook for us, giving us 1, 2, 3, 4, 5, 6. So thank you for those pearls. Dr. Srilata, proteinuric, non-proteinuric DKD, management differences.
As per textbooks, diabetic kidney disease is a proteinuric disease. As one of the other indication for biopsy is diabetic abnormal GFR without proteinuria, where mainly tubulointerstitium is affected. So this is we call it as a renal macroangiopathy of diabetes. So regarding the management, the proteinuria is not at all significant in tubulointerstitial diseases of macroangiopathy. So whether the role of ACE inhibitors ARB is not that foolproof. And most common cause of significant tubulointerstitial disease is associated atherosclerotic vascular disease. So most of them will have renal artery atherosclerosis. So ACE inhibitors ARB may produce some further fall in GFR. So you have to be careful in using ACE inhibitors and ARB in this. And another problem, once they develop clinically present with a macroangiopathy with tubulointerstitial disease, their progression is little slower than a glomerulopathy. So that is why the term has been changed from diabetic nephropathy to diabetic kidney disease. Currently, diabetic nephropathy is used exclusively for predominant glomerular changes. And once it involves the entire compartment of the kidney, we use the broader term of diabetic kidney disease. Management-wise, there is no significant difference.
Thank you on that. Dr. Varsha, and from my end, the last question to you, the cardio-renal connection, basically role of statins. Please give us your opinion.
Yes, so there is definitely a connection, and we all are aware that how we call diabetes as a, a cardiac risk equivalent. So similarly, CKD is also a coronary heart disease risk equivalent. The chances of CHD are very high in CKD patients. And in the initial stages, the different trials with statins have definitely helped. The dosages of statin that you would like to give in a CKD might be slightly different from our other diabetic population. But when it comes to secondary prevention, then it is better to give the highest tolerable dosages of statins when it comes to secondary prevention. So like, for example, as a secondary prevention, suppose if you're giving atorvastatin of 40 milligram in a non-CKD diabetic population, then for a CKD population, if the patient is able to tolerate a dose of 20 milligrams or 30 milligrams of atorvastatin, so you would use that. Okay, and when it comes to say the end stage kidney disease, then that area is quite controversial, and the use of statins over there has not really shown much benefits. There have been certain risk of a stroke and all that, and so prior to end stage kidney disease, yes, definitely statins should be used with the caveat that the dosages need to be modified depending upon the patient's acceptability. The chances of muscle toxicity are more in those patients with CKD patients, so we have to watch out for that as well.
Thank you so much. Well, I think we are today done with panel 1. Any questions, Dr. Priya, that we need to address or?
Yes. I think there was a question on the dose of Fineron depending upon the eGFR. I think that's answered here in the chat box. Yeah. Any further questions can be typed in the chat box, please.
All right. If that's adequately addressed, can we close this session then? Thank you, everyone. Pleasure and privilege.
Thank you so much.
With that, we hand over back to you, Dr. Priya, to continue on. Thank you so very much, everyone.
Thank you.
Thank you.
So we had a magnificent discussion about diabetic kidney disease, and thank you panelists, and thank you Dr. Priya Balani for excellently moderating the session. And I think the key message is generating more awareness about diabetic kidney disease in the community and referral to the specialist at the earliest. So we move on to the second panel discussion for today, which is a comprehensive approach about chronic kidney disease and mineral bone disease, CKD MBD. And for this, may I take this opportunity to invite Dr. Tapoti Mukherjee, who is a consultant nephrologist from Manipal Hospitals, Bangalore. Please introduce the panelist and moderate the session, ma'am. Thank you.
Okay. Can I have the next slide? Thank you, everyone, thank you, the organizers, for inviting me to moderate this session. And I would like to congratulate and thank the previous, the speakers and the panelists and the moderators of the previous session. It was a very, very enlightening session. I really thoroughly enjoyed it. I take the privilege of introducing the panelists present for the next discussion, which is a very, very relevant topic in CKD, that is mineral bone disease. Now, as nephrologists, we are aware that CKD MBD is extremely prevalent in 60% or 70% of our CKD population across all stages. But I would still say that it is quite an underestimate, because we often have to weigh between several factors of CKD optimization, and we don't. And even the denial of the patients is much more high, because mineral bone disease often doesn't produce any symptoms until it is really, they have something more devastating. So I'm looking forward to this discussion. It's my pleasure to introduce the panelists here. Dr. Sahana Shetty, she's an endocrinologist. She's an alumnus of CMC Vellore. She's had more than 50 publications in national and international journals, and she's received the silver medal. She's been awarded the silver medal for research for vertebral fracture assessment along with BMD. She has received the gold medal for her research on bone turnover markers, and she's also been awarded the silver medal for research in hologic versus ICMR database in the diagnosis of osteoporosis. Welcome, Dr. Sahana Shetty, and looking forward to hearing more from you. Dr. Vaishali Deshmukh, she's also an endocrinologist. She's a consultant and head of endocrinology at Dinanath Mangeshkar Hospital and Deshmukh Clinic, Pune. She was the invited faculty for over 1,000 CMEs, webinars, interviews, conferences. She is the founder and secretary of an NGO called Sphere. She is part of the Deshmukh Clinic and Research Center. She has been awarded the gold medalist for a Proficient Woman Award, Kranti Surya Pratisthan Award, Adarsh Mahila Puraskar, Jeevan Gaurav Puraskar. She's had 26 publications to her credit. She's had around 25 years of teaching experience. She has authored chapters in 5 books. She has been involved in several researches and clinical trials in endocrinology. Her special interests are mind-body medicine, neurobehavioral endocrinology, endocrinology in women. She's also been an organizer in the Synapse Conference 2020, Geriatric Endocon 2020, Endo Gossip Series. That's interesting. Women and Diabetes 2020, Synapse 2021. Welcome, Dr. Deshmukh. It will be a pleasure to have you here. Dr. Indira Mesnam, I hope I've got your last name correctly. She is a senior consultant endocrinologist in the Department of Endocrinology, Charnock Hospital, Kolkata. She has had 52 publications to her credit. Welcome, Dr. Indira. Pleasure to have you here. Dr. Kiran Mai is my fellow colleague in nephrology. She is a consultant at Osmania General Hospital. She's had several major achievements to her credit, which include awards as Best Outgoing Student in DM, the Mahesh Narayan Memorial Gold Medal Award. She's had several publications to her credit. She has authored and co-authored in several publications, and she has also participated in several conferences. Welcome, Dr. Kiran Mai. Looking forward to hearing more from you. And the last panelist here is Dr. Namrata Rao, also my colleague in nephrology. She is an alumnus of PGI Chandigarh, and currently she's working as an associate professor in Dr. R.M. LIMS Institute, Lucknow. She's had several publications to her credit, including original articles, case series, case reports, review articles, and conference papers. Her particular areas of interest in renal biopsies and their safety aspects, mineral bone disease and phosphate kinetics in CKD5D, dialysis-dependent patients, nutritional evaluation and management of CKD. She's received several awards and honors, as one of which is Best Clinical Researcher for the research team. Welcome, Dr. Namrata.
Thank you, ma'am. Thank you for the kind introduction. Thank you very much. Looking forward to the interaction. Very proud to be part of such an elite group. Thank you.
Thank you. Dr. Sahana, can I have the first question for you, Dr. Sahana?
Yes, I can hear.
Can you hear me? Yeah.
Yes, yes.
What is the spectrum of CKD, of the mineral bone density that you see in CKD? And how does kidney disease affect biochemical markers of bone turnover in general?
First of all, I would like to thank the organizers for the invite and to be extremely happy to be part of this allied group. So when we talk about CKD and MPD, we know that it includes a whole spectrum of disorders of mineral metabolism and bone disorders, starting from the bone mineral metabolism, which to begin with starts with increased FGF23, then you have reduced in active vitamin D, you have hypophosphatemia, low calcium, raised hyperparathyroidism. This includes the mineral metabolism defect. Then you have the bone defect, which again has spectrum where it starts from a high bone turnover to a low bone turnover states. In addition to this spectrum, it also includes heterogeneous classifications or calcifications, increasing the cardiovascular risk and all-cause mortality in CKD. So when we say CKD, MPD, it is just not mineral residual bone disorders. It includes all of this spectrum. Specifically, if you're talking about the bone defect in patient and the spectrum in CKD, now this includes three spectrums, three different categories. So you have a high bone turnover state, also called as state of predominant hyperparathyroid disease related bone pathology, where you have predominantly increased bone remodeling with increased bone resorptions, to some extent also increased bone anabolism, but a defective anabolism state. So it's predominantly increased bone resorptions. It's also named as osteitis fibrosa cystica. On the other extreme, you have the low turnover state, also called as an aerodynamic bone state, where you have predominant inhibition of the anabolic effect of the bone, that is the osteoblasts are inhibited and you have an aerodynamic bone disease. In this, you also include another entity, which is an aerodynamic bone disease or a mineralization defect due to aluminum toxicity or even vitamin D deficiencies or use of bisphosphonate, etc. Then you have in between these, you have a combined spectrum where you have both high bone turnover and a mineralization defect, which is called as a mixed type. So you have these three spectrum of renal osteodystrophies in this CKD MPD phenotype.
In your practice as an endocrinologist, do you come across these patients with a different spectrum of CKD MPD? Because once the person is an advanced CKD, the nephrologist ends up managing many of the problems. But are they really referred to you, or do they independently come to you for a detailed analysis?
Yeah, I think if they're kind of fitting into the the expected spectrum, they might not refer. But sometimes you have patients with tertiary hyperpara, or otherwise we do come across. And many times we have patients with diabetes and CKD, diabetic nephropathy and CKD MPD, which we are managing together. So we do see. And sometimes if you want to rule out other causes, then of course these patients are referred to us.
Thank you very much, Dr. Sahana. I would move on to Dr. Kiran Mai. Dr. Kiran Mai, how often do we monitor calcium, phosphorus, vitamin D3, PTH? I know we have set guidelines, KDOKI and KDIGO guidelines, which asks us to monitor for mineral bone disease every month, or at least the PTH every 3 monthly. But how often do you end up doing that in our practice? Because as I mentioned, we are often dealing with trying to balance out several nitty-gritties in a CKD, especially one who is on dialysis. How often do you monitor the parameters of mineral bone disease? Or
that's a good question. Actually, all of us are aware of the CKD classification. It depends upon the GFR. So your GFR stage 1, stage 2, stage 3, and again the stage 3 is divided into A and B depending upon your GFR, and stage 3 and stage 4 or end stage. So your GFR in stage 3, you need to start your monitoring when you come across a patient with a GFR of less than 59, if they fit into the stage 3A or B. So stage 4 and stage 5. So each stage, the monitoring would be different. For stage 3A and B, the monitoring is done at every 6 months for the serum calcium, serum phosphate, and a baseline level of PTH is done whenever you see the patient. So if they fit into stage 4, The monitoring of biochemical parameters would be done at every 3 to 6 months. And if they come into stage 5 or end stage renal disease, the monitoring done more frequently for every month or 1 to 3 months. The baseline vitamin D would be done for all the stages at the baseline. And as per the therapeutic implications, you can repeat it also as per the guidelines. And PTH is done depending upon the stages. Stage 3A and B, you do it at 6 to 12 months interval. Stage 4, 3 to 6 months. And at stage 5, you will do it between 3 to 6 months. So each stage is different, and the guideline recommends for each stage are different, ma'am.
Are you able to follow the same in your practice as mentioned in the guidelines? Because
of course, yeah, we do it because it is essential. We correct it or we identify the disorder very early. So it's always better. By the time the patient comes to us, they are usually into stage 5, ma'am. They doesn't come in stage 3 or 4 at all.
So, particularly in the elderly with other reasons for osteoporosis, and you probably want to identify these because a fall is something very worrisome in even in the younger patients. They just have an unprecipitated, untriggered fracture somewhere. And
so for the women population, it's better even for the CKD MBD where the risk is very high. So we have to evaluate as per the guidelines.
And how do you replace vitamin D3 in chronic kidney disease vis-a-vis the general population?
Actually, the guideline says to evaluate vitamin D in each and every stage at the baseline level. And they recommend that vitamin D deficiency or insufficiency has to be treated as per the general population, even in CKD patients also. So how do you treat for the general population, the guidelines, whatever they
There's no difference.
Will be used or applicable for this population as well.
I think the challenge in our population becomes when the phosphorus is high, and being over enthusiastic about giving vitamin D. We'll have to monitor the phosphorus more closely because that is also another concern in our population.
Yes. Though Gettigo says the same guideline will be applicable as for the general population and the CKD, but when coming to the use of vitamin D analogs, it is completely different. It doesn't recommend at all because of the risk of hypercalcemia. And as you know, it's a big risk factor for the cardiovascular morbidity.
Absolutely. Thank you very much for throwing light on vitamin D replacement and how we monitor the parameters of bone mineral homeostasis and CKD. Dr. Vaishali, if I were to ask you a few questions, how do we treat osteoporosis in CKD? That is the first question.
I think it's a very
this is something, it's quite a hot topic these days, and the more we know, the better it is. And the more we share each other's experiences, I think it is good. Can you throw some light on that?
Yeah, thank you, Dr. Topati. And I think this is the right forum to discuss this topic because we have a lot of women here and women who deal with a lot of osteoporosis. But it is very tragic and ironical that in so many years of my practice, I've seen so many CKDs with osteoporosis, but none has been referred by nephrologists. They have been referred by orthopedicians because of fracture and diagnosis. So I think it's high time that nephrologists start actively screening and referring. That is one thing which I can definitely pass on this forum. And definitely it's a very common coincidence that you have renal osteomalacia as well as osteoporosis. Very commonly seen in all our CKD patients. Now CKD right from stage 2, 3, 4 onwards, as soon as the EGFR starts falling below 65, this whole process starts. So it is as early as that. And I'm sure all the nephrologists come across patients with a EGFR below 65. So all your patients are at risk of osteoporosis, especially if they are postmenopausal, especially if they are diabetic, and especially if they have active bone disease history in their families. So I think this population of renal patients need a detailed screening. The commonest recommendation for osteoporosis screening by the IOF guidelines is based on the T-score assessment. So T-score assessment should be done for all your renal patients. Now, of course, age is one of the factors. We have a Frax tool on the online, which like a calculator, you can calculate the fracture risk otherwise, and then you can add on the renal risk to whatever is there. So if the fracture risk is very high in that particular patient, definitely that patient needs an immediate evaluation. Second important point is that we all as nephrologists, as endocrinologists, do a lot of biochemistry. But what is important to be harped upon is that we fail to keep our attention to normalization of phosphorus and calcium ratio, which is a mandate for maintaining bone health. So 3 factors are very important. One is maintaining a normocalcemia. Second is maintaining a normal phosphatemia, maintaining a normal alkaline phosphatase, and then evaluating the bone density. Once you have done all these 4, you have come to a conclusion that whether the patient has normal bones or no. If the patient has a normal bone, you need not evaluate further, like doing a PTH or other assays. But if this is abnormal, any of this is abnormal, then this is a patient where you should be evaluating for the PTH. Now, as Dr. Sahana rightly mentioned, that you have different types of bone disease that are coming in renal disease. So it is important to identify whether the osteoporosis is normal turnover, high turnover, or low turnover, because your therapeutics depends on that. So treatment of osteoporosis would vary depending on what you get in your biochemistry and your clinical evaluation. So once I know that the commonly seen is a high turnover osteoporosis. So you get very rarely you get a low turnover osteoporosis with the adynamic bone disease in the later stages. So you can say that around 80% of the patients would be high turnover or normal turnover patients. Now, if you have to see in terms of treating these patients, reduction of the turnover is one aspect, building up the bone is another aspect, prevention of fall is a third aspect, and building up the protein and muscle strengthening is the fourth aspect. So it is a overall teamwork. It can't be a single doctor or a single person managing osteoporosis. So you involve a bone team. So you involve educationalists, you involve a nurse, you involve a dietitian, you involve a nephrologist, orthopedician, physiotherapist, all together in the team. And that is what forms actually a osteoporosis team. So whatever patients I have come across are mainly patients on dialysis who have had hip fractures or fractures, and then they have been referred with the diagnosis of osteoporosis, or renal osteomalacia patients who fail to walk in, or renal tubular acidosis who are not diagnosed at the right time and they have come from the orthopedician. So these are the common scenarios with which osteoporosis would come to a nephrologist. So having said that, the treatment now. So treatment wise, as we mentioned that you need to have raw material to build up the bone. So you need a proper calcium, vitamin D supplementation. And I'm sure all of you are much more well-versed with which formulations are preferred in nephro patients. But if you have to help this calcium and phosphorus build in the bone, then you need to give the anti-resorptive agents or anabolic agents, depending on the turnover. So if you have a high turnover osteoporosis, you would reduce the turnover by giving certain anti-resorptives. So anti-resorptives, commonest which are used are bisphosphonates, and second is the denosumab. And second, anabolic type of drugs are commonly the teriparatide group, and some action with denosumab is expected, and we are getting newer and newer drugs. Now the question comes as to, in renal patients, what is the need to pay attention to? So basically, all the bisphosphonates are used with caution whenever the eGFR is below 35. So between 35 and 65, you have the option of using bisphosphonates in the right doses. Commonly, oral bisphosphonates are the easiest and most sufficient to be used. When you're thinking about treating eGFR below 35 or 30, then only safest molecule available is denosumab. And the ease of administration and giving denosumab is relatively easier. Of course, cost is a concern.
Cost is a major factor, true.
Yeah, but we are getting certain biosimilars which are cheaper. So you can try those also in that situations. And apart from that, one needs to remember that the denosumab has a disadvantage of causing hypocalcemia. So you cannot give all these agents unless you have normalized the alk-phos and the serum calcium level. So we need to watch for electrolyte, the calcium phosphorus imbalances which occur during therapy. So they need a bit of monitoring. So I think it's a big activity, and it should be a parallel plan for bone management of CKD patients. So I think this is a right way to start and initiate and then go ahead. Of course, treatment for osteoporosis, the freedom data says anywhere up to 5 years. and can be extended up to 10 years. So we have seen that the fracture risk in nephropathy is very high. Using these agents are known to improve the quality of life, the muscle strength, and the overall risk of fracture is much lower in such patients.
You've made very relevant points because periodic monitoring and optimization of CKD, MBD parameters, which should include the protein, the albumin, and the bicarbonate, is very, very imperative in early identification of patients at risk for fractures or other.
There is a comment in the box saying that steroid usage is going to cause osteoporosis. So I have not covered secondary osteoporosis into this at all.
We'll come to that because we'll talk a little bit about transplant bone disease also. So we can discuss the steroid part and other.
So secondary osteoporosis is another spectrum altogether beyond what I spoke.
No, we will be speaking about bone disease and transplant recipients, so we can cover that then. I had another question for you. How would you differentiate between secondary and tertiary hyperparathyroidism?
Yes, so basically it's a basic lab diagnosis, but clinically if you want to suspect, tertiaries are usually very severe in terms of bone disease. Secondaries may be normal or severe. So it can vary from the spectrum from normalcy to severe. The bone disease may be very mild to very severe in the form of fractures and various other comorbidities like proximal muscle weakness. Patients may be bedridden also. Now, coming to the lab diagnosis, you have, as I said, you have a calcium evaluation, phosphate evaluation, and ALK phos. When the ALK phos is high, definitely there is a predisposing ground for a rise in PTH. So you do a PTH in such a patient where the ALK phos is high, and the PTH when it is on the higher side, and the system EB scan of this patient, especially in a setting of hypercalcemia, it makes you suspect tertiary hyperpara. So when you have normocalcemia, the chances that it is secondary is very high rather than tertiary. So when you have hypercalcemia, high ALK phos, high PTH, the next thing you do is a system EB scan to see for a parathyroid adenoma, and you diagnose a tertiary. If the same scan is negative, then it may be either a known localized or a very small parathyroid adenoma, or it could be just a severe form of secondary hyperparathyroidism. But hypercalcemia may not be explained by this particular pathology. So when hypercalcemia is present in a setting of osteomalacia, I think you need to suspect tertiary as the primary thing.
Thank you, Dr. Vaishali. You've given very insightful inputs. Dr. Kiranmay, if I were to ask you, how do you interpret PTH in CKD? As we know, it depends on the stage. At every stage, there are different cutoff marks. Can you throw some light on the interpretation and the threshold for raising the alarm button?
Yes, ma'am. So the PTH, what is the basic physiology? PTH, after the synthesis, what happens? It undergoes a cleavage or proteolysis in the liver and converted into an active amino group and an inactive carboxyl group. So the active amino group, which is biologically active, has a half-life of 2 to 4 minutes, and it is immediately degraded by the liver and kidneys. But the carboxyl group, which has a half-life of 1 to 2 hours, is released into the blood and it is subsequently cleared by the kidneys. So why is this fact important? This carboxyl group tends to accumulate in CKD. So this can influence the PTH, actually PTH levels also in CKD. So we have to remember this fact. So what are the assays that are done for PTH analysis, and why are they important in CKD? The PTH is measured, the first generation assays are different, they're obsolete now, but the widely done second generation assay, it recognizes the active part amino group as well as the carboxyl group, and most importantly, it recognizes the carboxyl group which has attachment of amino group as well. So this assay is done by sandwich immunoassay, which is done by using the monoclonal antibodies. 2 antibodies would be used. So the one antibody is used towards the carboxy terminal, and the other labeled antibody towards the active amino group. So what happens? It also, apart from these, the assay would also recognize the end fragments which are accumulated in CKD. You have to remember this, because of 50% of PTH levels will be influenced by these fragments. So to improve this assay, they have utilizing the third generation assay, which is known as biointact or bioactive or a wholesome assay. But unfortunately, this assay is not comparable to second generation assay. And unfortunately, the results provided by this assay are 50 to 70% of the intact assay only. This is the reason the KDIGO is recommending the second generation assays only, because of these facts. And this has to be, the second generation assay has to be used for the CKD population because of these facts. So what does it recommend? KDIGO recommends how frequently you estimate the PTH. It depends again upon the CKD stage, as I already told. It could be 6 to 12 months, it could be a baseline at stage 3 and 6 to 12 months, and again 3 to 6 months at the end stage renal disease. So the second generation assay would be helpful in coming up in measuring the PTH. As I told you, all these factors will influence the levels also, but KDIGO doesn't, it recommends not to treat the hyperparathyroidism, and it recommends to treat the modified risk factors like calcium, phosphate, and vitamin D before coming or addressing the hyperparathyroidism. And it also doesn't recommend any usage of vitamin D analogs in the stage 3A to stage 5 if they are not on dialysis. This is because of the risk of hypercalcemia, and the sea change in the decision has come because of the two important trials, which are the Primo trial and the Opera trial, which have not shown any benefit in spite of using the paracalcitol in the population, and they have shown an increase of 22% of hypercalcemia in the population, as well as 43.6% in the Opera trial. So based on this trial, the KDIGO has not recommended any usage of vitamin D analogs in the non-dialysis group. But depending upon the PTH level, if it is progressively and consistently increasing, or after addressing all the factors, you can use and you can reserve these analogs for the severe hyperparathyroidism. So the PTH can help in these situations.
In CKD5, what is your cutoff for or what is your target of PTH?
No, you can treat above 300 micrograms, ma'am, if the PTH level is above 3 and associated with the symptoms. And especially if all the other factors are addressed. So even the KDIGO says a 300 of a cutoff value.
Thank you for throwing light on monitoring of these parameters, which many a times as in dialysis, we just, patients do not want to spend extra, but it's very important to keep counseling them about the importance of, especially in many of the elderly, a fall is kind of a beginning to the end. And if we can identify these things early and preempt certain things, it is really very useful.
Yes, ma'am.
Thank you, Dr. Kiranmai. Yes, Dr. Namrata, how do we target serum calcium and phosphorus in CKD?
Thank you, India, and thank you, ma'am, for the kind introduction. I mean, the targets and the levels have already been discussed by the previous speakers, and the question comes as to how do we target it? Like, as in, like, how do we target the high phosphorus that is there in CKD non-dialysis as well as in CKD dialysis dependent? In CKD non-dialysis dependent, overall the data for hyperphosphatemia control is not very robust. Large studies or meta-analysis of RCTs has not shown that controlling phosphorus leads to actually hard clinical benefits such as mortality or other benefits of that kind. Most of them have been on intermediate parameters or even biochemical parameters, rather PTH and other things, rather than actually hard clinical outcomes. Some studies, not very robust ones, but those including large retrospective data, have shown that maybe if you give phosphate binder therapy to patients who are on who are having hypophosphatemia, but in non-dialysis CKD, they do show some degree of mortality benefit, etc. But the picture is not clear. So even now, telling non-dialysis dependent patients to keep a phosphorus target is not evidence driven. It is still in a gray zone. Now coming on to how do we target that high phosphorus? In dialysis, it's very clear, cut and dried. We have three things that we can do. One is we do dialysis, we remove the phosphorus, then we control the diet so that we are giving less phosphorus in the diet, and third, we are trying to give phosphate binder so that we reduce the GI absorption. But in non-dialysis CKD, again, we are
the
removing the major dialytic. The 3Ds basically. So dialysis removal, again, in a country like India, where probably about 60 to 70% of patients are on twice per week dialysis, we are looking at a removal of, let's say, 600 to 900 mg per session. And so not more than 2000 mg in a week for at least 60% of our population. And we contrast it to at least 1000 mg per day of intake.
Is the intake.
Of intake. And also, let's say just a 60% absorption on that. That again, we are not clear as in how it is with India. But then if we are taking in a predominantly plant-based diet and, everything else is going the phytate way and all that, then probably we expect that at least half of it must be getting absorbed. And so basically, we are still ending up with a substantial deficit in terms of phosphorus removal, for all of which we depend upon phosphate binders. And phosphate binders, of course, contribute to the highest pill burden. By the time we go into dialysis sector, we are almost about 8 to 10 tablets of the entire pills are made up by the phosphate binders and so on. So overall, looking at that picture, it looks like in non-dialysis, let's not really go overboard with phosphate binders because data is not very clear. Probably we should generate data of that sort to show whether significant mortality benefit, other clinical benefit is being seen with that or not. Otherwise, dietary restriction also, it's a very tacky thing, especially in non-dialysis dependent CKD. They are more likely to be the diabetics, hypertensives who are showing to us with CKD 3 to 5. Some of them may have associated cachexia, malnutrition, etc. How are we going to be telling them to take a low phosphorus diet? So going for a low phosphorus diet is also not easy.
I very much agree to this point, and it is very challenging because we want our patients to eat proteins, and every protein comes with a package of potassium and phosphorus. It's impossible to eliminate, other than I think egg whites, which are zero phosphorus. Other than that, it's very, very difficult to give a very, very tailored diet for the patient. And they also need some, they always feel that they are deprived of several nutrients. But in the pre-dialysis CKD, I totally agree to your point. But in the dialysis population, I think it is probably more convenient to have a certain cutoff and to give a binder, and because their appetite also improves, so we have to chase the phosphorus. And
the additional problem with CKD non-dialysis, I feel, is that year after year you're telling them to do something. Say you take low protein, though we don't say. I mean, most Indian nephrologists are extremely sympathetic towards their patients, so we don't really go overboard with low protein. But then we're telling them don't take all these fruits and veggies, take very limited stuff, take low phosphorus, don't take meats, and do this year after year after year. And we make our patients land up with constipation and other things because obviously we are reducing fiber intake. Almost everything that we are doing is more or less facilitative to a poor diet in our patients. And then we tell them that you have to keep doing this so that you don't land up in dialysis. It's possible that in dialysis, this patient is going to have a much better nutrition rather than what he has spent in the whole time actually progressing to dialysis. So phosphorus management is a pain in non-dialysis CKD.
It's a pain, and I think the role of a renal nutritionist is very, very important here. Something that we as nephrologists, we cannot manage that. And if there is a renal nutritionist, it's of a lot of help in managing and balancing everything.
About 2-3 years ago, ma'am, I had teamed up with a dietitian group to actually make a food frequency questionnaire for this region where I am. I'm practicing in Uttar Pradesh. So basically, I was just looking at in terms of what were the phosphorus contents, etc., in commonly made Indian foods, and these are not widely published anywhere. If you type in a hamburger, you type in a sandwich, you're going to get the information on this in 2 minutes. You can go onto Google, your patient can easily check what is the phosphorus content of his sandwich. But for the typical Indian foods that we eat, like an aloo paratha or a chapati or, upma or whatever, we do not have similar, dietary information also which is available. So telling our patients to go on a phosphorus restriction to check and eat, even if our patient is educated, it's very difficult. It's actually quite difficult for them to go on to that. So maybe as a collaborative, we need to come up with something which we can associate with dietitians and also give some information which is very specific to our patients in terms of Indian food.
As Dr. Vaishali mentioned, that CKD is a very, very multidisciplinary approach. It's the nephrologist, the vascular surgeon, the nutritionist, the psychologist, the endocrinologist. It's really actually a multi-system thing that we are dealing with in CKD.
And again, calcium based, even as you said, to maintain calcium. I mean, many of our patients are at the brink of actually going into 1.5 to 2 gram calcium because many of them are non-fitting for, let's say, non-calcium binders. Such patients would be on the brink of taking about 1.5 to 2 grams of calcium. And we are scared of going overboard with that. With diabetics, we do tend to advise them to go for sevelamer or lanthanum or so on, but it's very difficult to, find the ideal set of patients who would not be going overboard with calcium. Also, this is typically seen in patients who are taking energy-dense foods, like the diabetics who are coming to us from, let's say, general practice. They would be taking those oral nutrition supplements, which are meant for, let's say, non-diabetics. That also tends to cause problems in terms of phosphorus and calcium. And that is another problem that we need to tackle at the level of the nephrology service.
Thank you for that. I have another question for you. What is the role of recombinant growth hormone in CKD-MBD?
Ma'am, I actually did not anticipate this particular question, so maybe I'll have to. I'd probably take some time and get back to you on that.
Okay, no problem. So I can. One more question for you, Dr. Namrata, is how do you evaluate kidney transplants in bone disease? Kidney transplant bone disease.
Ma'am, with regard to this, there was another thing that I thought of probably asking in terms of this panel was that we all have a practice of evaluating our kidney transplant, perspectives completely. And over the course of that, we do see that the majority of our patients are, having a high PTH value. When we look at guidelines from other places, like let's say Japan has, very peculiar and particular guidelines for this. But according to certain guidelines, it is said that if you have really high PTH levels, patients can undergo even a parathyroidectomy in lieu with or prior to actually undergoing a kidney transplant. But when it comes to most of our practice, we expect that, PTH would normalize over a period of time, and we do not usually go in for such major surgeries prior to transplanting our patients. And I guess, at least in my practice, I've seen majority of my patients have PTH values of 500 to 1,000 when they come.
But prospectively, do you monitor their bone mineral density after a transplant period?
Yes, ma'am, we do. So
all of them are on steroids.
Yeah, we do that. So once the patient is transplanted, then hypophosphatemia is universal. Almost 80 to 90% of them are hypophosphatemic unless they are having a poor graft function and so on. And most of us nephrologists also believe that hypophosphatemia is a good thing because it means that the graft is functioning well. And when you look at even long-term mortality data, it shows that graft function and mortality both are better in patients who have some degree of hypophosphatemia. But again, we do not know how much of this hypophosphatemia also contributes to some other outcomes. Like let's say when we look at BMD in a longer long term, like let's say 2 years, 3 years, it is known that transplant patients, though they have better bone density at 1 year when compared to a patient who's on dialysis, their bone density tends to worsen over the next 2 to 3 years. We usually tend to blame it all on steroids, but are we sure that we do not have other things to blame this on? I mean, some degree of persistent hyperparathyroidism or some say some degree of hypophosphatemia. All these things also may be contributing to the post-transplant kidney bone disease. So again, at least at 2 to 4 months after a transplant, patients should be evaluated for a complete workup, calcium, phosphorus, and bone mineral density as well can be done at this time point. If we are looking at a DEXA-based abnormality, then we go ahead and do the bone turnover markers. And depending on the turnover markers, I think Vaishali madam had already spoken regarding use of anabolic agents versus anti-resorptive agents based on whatever parameters we do see. So that would be as far as evaluation of the transplant kidney bone disease goes.
Thank you very much, Dr. Namrata. We are moving towards the end of this session. I would like to invite Dr. Indira. My questions for you, Dr. Indira, are the role of bone biopsy.
Okay. Thank you very much for having me here. So bone biopsy would be done in very limited settings because of the fact that we have very little expertise regarding the biopsy as well as the interpretation of it. And according to the KDIGO guidelines 2017, bone biopsy may be indicated in those individuals where the biopsy may actually change the course of the treatment. So who are the individuals who may go in for a bone biopsy if, let's say, they have worsening of the BMD despite appropriate treatment, if they have refractory hypercalcemia and things like that. So the purpose of the bone biopsy is actually to identify the conditions which could be atypical or, let's say, unexpected, and also sometimes to differentiate this one, what do I say, the high turnover as against the low turnover bone disease, because that will again that would again change our style of treatment of whether we will and another thing is, another important thing about the bone biopsy is also when osteomalacia is suspected, especially whether it is because of aluminum excess, which is rare nowadays, or because of calcium and phosphate deficiency. So firstly, it would be very limited settings we would be doing, and when we do so, it would be with certain indications. And ma'am, I would also like to take that question on growth hormone, which you actually asked Dr. Namrata. Yeah, so thank you, because that is a very important question. And that is one of the reasons initially in the beginning of the conversation, you had asked like how many of the CKD patients actually get referred and for what reasons to endocrinologists. So one important reason is failure to grow. So in that case, we may provide recombinant growth hormone in individuals, in children who have short stature as defined by a height percentile of less than 3% or a height velocity that is less than 25 percentile. So, but before that, we need to assess the important causes of growth failure in CKD patients. And therefore, we need to address the malnutrition, the metabolic acidosis. We need to address the CKD MBD, which is our topic of discussion today, because let's say a very high PTH level would actually interfere with the response to the growth hormone, and also may induce other growth hormone induced complications like slit femoral epiphysis, other conditions like let's say other conditions or like anemia. All these things need to be addressed. Now, firstly, we have to document, and why growth hormone in CKD patients? Because it's not that there is growth hormone deficiency, rather there is insensitivity to growth hormone. And we know that the IGF-1 is a final common pathway for growth hormone, where growth hormone acts on the growth plate. And therefore, we would measure the IGF-1 levels, but not the growth hormone levels, because these patients are resistant, and therefore the growth hormone levels would be normal, or it could even be increased. So before starting growth hormone, we would have some preliminaries like the height of the child and whether there is potential for growth, in the sense that whether there is fusion of the epiphysis. If the epiphysis is fused, then we can't give. Again, we need to rule out certain contraindications to growth hormone, the presence of proliferative or the non-proliferative diabetic retinopathy or retinopathy per se, or let's say the presence of active malignancies. And also in patients with renal transplant, we have to, usually after renal transplant, there is a catch-up growth that occurs. And if the catch-up growth doesn't occur in the 1 year, and if there is a need for continuance of steroids, which is in most of the cases, in that case, we start giving the recombinant growth hormone at a dose of around 0.045 to 0.05 milligram per kg subcutaneous daily. And then we continue the growth hormone till the target height has been achieved. What is the target height? The target height is the mid-parental height, that is the average of the parent's height, plus minus 6.5 centimeter plus for boys and minus 6.5 centimeter for girls. whether if the target height has been achieved, and also when the height gain is less than 2 centimeters per year.
Thank you. That was very informative. Can I have one last question for you? And that is, what is the role of calcium mimetics?
Okay, so again, interesting questions. So we know that calcium mimetics are, they increase the sensitivity of the calcium sensing receptor to calcium, and thereby they are used in hyperparathyroidism. So in the context of CKD, MBD, what the KDIGO says is that we may use calcium mimetics in those individuals who have very high IPTH levels of more than 2 to 9 times the upper limit of normal. Obviously, as has been pointed out by previous speakers, we need to address conditions that may increase the phosphate level. Specifically in this 2017 guidelines, they have spoken about the reduction in the phosphate in the diet. And then we may use the calcium mimetics in patients with CKD on dialysis. And specifically, they could be preferable in those individuals who have hypercalcemia. So and another thing about the calcium mimetics is that, yes, what is the advantage of calcium mimetics? They would decrease the parathyroid hormone levels. They can tend to cause hypocalcemia, and therefore it would be preferable in those individuals who have high calcium levels. But the EVOLVE study, what it did, it found that it did not improve the cardiovascular or the mortality outcomes in individuals who are less than 65 years of age. In more than 65 years of age, there was a signal that the calcium mimetics like cinacalcet improves the cardiovascular and mortality outcomes. And also, so if we look at the pharmacotherapeutic agents for the control of primary hyperparathyroidism, we know we have calcitriol, we know we have this analogs, vitamin D analogs, and we have cinacalcet. Now, what the KDIGO says is that which is preferred cannot be said. It depends on individualization of the treatment in those individuals. So if the patient has hypercalcemia or a tendency to hypercalcemia, then a cinacalcet that is the calcium mimetic would be preferred. Whereas if the patient has hypocalcemia or does not have hypercalcemia, then maybe a calcitriol or a vitamin D analog would be preferred. They have not mentioned the use of the calcium mimetics in patients of CKD who are not on dialysis, but I think in your practice also, ma'am, and even us, I think sometimes we also may have to use calcium mimetics when the parathyroid hormone levels tends to be very high.
Thank you very much, Dr. Indira, for your answer. If there are any more questions from the audience, we would like to take that.
I think, ma'am, we have 1 or 2 questions in the chat box.
Mm-hmm.
So, do we have any checklist prior to starting bisphosphonates in a patient with CKD? How do we have a baseline? At what levels of calcium, phosphorus, IPTH we can start off with a bisphosphonate, and how do you monitor the same with respect to the duration? How long it should be given when the patient is put on bisphosphonate?
Anybody from endocrinology would like to take that question?
Yeah, I'll answer that. So basically, before a bisphosphonate is started, you need to evaluate the calcium, phosphorus, alkaline phosphatase, and the EGFR. So once the EGFR is above 35, you can think of bisphosphonates. And PTH may not be done if cost is an issue or if the alk-phos is absolutely normal and the calcium and phosphorus is normal. But if you want to do a complete workup, you should be doing a PTH as well as a vitamin D level for these. But these are 2 costly investigations. When cost comes into consideration, the basic level is calcium, phosphorus, alk-phos, and a renal function. So this is a mandate. Now, as to whom should you start on bisphosphonate, you should be doing a T-scoring with a bone density. Now, if you don't have a bone density in your place or you don't have a DEXA scan available, the least you can do is calculate her or his fracture risk based on the FRAX calculator. If the FRAX risk is already high, then CKD is going to definitely add on that risk. So you're not doing anything wrong to the patient. But if the risk is low, then it is better you advise for a T-scoring and get a proper classification. Now, in the DEXA scan, if you get a T-score more than below minus 2.5, that is the time you think of starting osteoporosis therapy. Otherwise, in between the range of osteopenia, it is better to control with calcium, vitamin D, and allied measures of bone strengthening. Now, if you're starting a bisphosphonate, you have two options, either to start oral or IV. Now, oral is indicated where patient is absolutely stable, can tolerate orally, has no GI upsets. So you can use either a alendronate or a risedronate or a ibandronate, and you need to use the dosage appropriately prescribed for those particular indications according to the eGFR. Now, if you are using IV bisphosphonate, zoledronate IV is the preferred drug, and that too you need a bit of monitoring of your calcium levels while you're giving all these drugs. So calcium is known to lower after bisphosphonate therapy, so there is a high chance of hypocalcemia. So ensure that the patient is going to have adequate calcium and is going to take adequate vitamin D, and the phosphate is going to be normal. So you need phosphate binding along with these things when you're thinking of starting on bisphosphonate. So I think this is the least we can start with, and probably then you consult for complicated cases. You have your endocrinologist come into picture and guide you on the further management.
There's one question that has come up in the chat box. What is the role of newer bone biomarkers?
Okay, so is it for me or it's for somebody else?
I
may
mean,
be the only person talking
question.
otherwise. Okay, so the bone turnover markers in renal disease is a very tricky situation because the renal tubular dysfunction exists. So normally if you ask me this question for just postmenopausal osteoporosis, I would have said urinary N-telopeptide is a sufficient marker to understand the resorption status. But in renal patients, we prefer to use bone-specific alkaline phosphatase because that's a serum marker. And usually it gives a good idea about bone turnover because you really can't depend on the urinary markers in renal patients. And when the bone specific alkaline phosphatase is high, it's again a costly investigation. So don't do it unnecessarily. Do it only when you are in dilemma. And if the bone specific alkaline phosphatase is high, you diagnose as a high turnover status, and then you think of giving anti-resorptive. So especially when you're thinking like a drug like denosumab or IV zoledronate, it is better to do this because most of the patients want to know what is happening. Why am I taking such a costly therapy? So they need that evidence through bone markers, because in the bone density, you will get the evidence only after 3 to 4 years. So even if you do a DEXA scan next year, it will show no change. So you don't need to repeat a DEXA scan every year. You need to do it every 3 yearly or 5 yearly, depending on how the patient is following up with you. You can save on those costs and instead use bone turnover markers for monitoring.
Thank you very much. Very, very insightful. Is Dr. Indira there?
Yes,
just
I
saw a
am.
message. So there's one question, probably you could take that. What are the chances of recovery of renal rickets in pediatric age group once renal dysfunction has set in?
Thank you. That is a very relevant question. As long as the renal dysfunction has not set in renal rickets, for example, like renal tubular acidosis, there are very good chances of the recovery of rickets, but definitely once the renal dysfunction has set in, definitely the chances, it is very much challenging, but before the onset of renal dysfunction, the results have been excellent.
Thank you very much. Are there any more questions?
If I can add, I'm Dr. Hannah here. I think there's a question by Dr. Namrata, rather a comment that uncontrolled phosphorus and PTH may be the reasons why bisphosphonates are not started. If I have to clarify here, actually what we are more concerned is calcium, especially more with denosumab, because denosumab therapy may cause hypocalcemia. Bisphosphonate therapies, if the calcium is real low when we're giving, it might cause some temporary acute hypocalcemias, which is again not that common. But phosphorus and elevated PTH, if we have given adequate say active vitamin D, then that's not really a contraindications. We could go ahead with the bisphosphonate therapy.
What I meant to actually ask was that most of the times we do have patients who are having persistent hyperphosphatemia or PTH, which has not come to 2 to 5 times upper limit of normal, which is what we follow as per guideline. So under that circumstance is like, I mean, because as Dr. Vaishali had pointed out that you should be giving your bisphosphonate therapy after you have like sort of normalized the biochemical picture. So that is what
that's
asking.
Not really for, no, what I wanted to say is that if you have a patient who needs therapy for osteoporosis, osteoporosis, we should make sure that the calcium is okay. But phosphorus and PTH, if you have already given the best of the management for that, and we still it's high, but it's not a contraindication for bisphosphonate, we can still go ahead with bisphosphonate therapy.
Just to clarify, Dr. Namrata, the anti-resorptive therapy has no effect on the phosphorus and the PTH levels. So you have to treat that parallelly. So it doesn't mean that when you're treating for osteoporosis, you're not treating phosphate and not treating PTH. So you have to go parallelly with that.
I think it's the GFR that becomes the major challenge in, GFR below 30 or 35.
I think denosumab is a very good molecule. I've been using
denosumab
it.
Denosumab is a very good molecule. It's only the cost that is still, and as
cost is worth the benefit, ma'am. The risk of fracture and the morbidity is much more. It's a 6-monthly injection, and usually what we do is we give it with a 6-monthly arakitol injection along with the denosumab, so that it goes hand in hand. So only you have to give calcium and phosphate binders otherwise. So it becomes an easy
denosumab is a very promising molecule. I agree.
Yeah, one point to add here with denosumab is it's an excellent molecule, especially in CKD, because that is the molecule we have for GGFR less than 30. We don't have much options.
Yeah,
but
true.
With denosumab, the problem overall, not just in CKD, but overall is that if you suddenly stop therapy, there can be risk of rebound fractures within 1 year of stopping the therapy, and there can be decline intensity, which is more than it was prior. So we should counsel the patients that they should not abruptly stop therapy. That is very, very important, because then we are doing more harm to the patients. So if it's been started, and also the right person should start the therapy, especially if it's a denosumab therapies, because then we are aware of those complications, and it's important to emphasize the patients that they should not abruptly discontinue therapy, which is rather not that much of a problem with bisphosphonates. We do give drug holidays.
Very relevant point, Dr. Sahana. Are there any more questions?
I think one more question is there. What are the indications of systemic scan, and what's the cutoff for IPTH? And are there any guidelines of bone health evaluation prior to starting SGLT2 inhibitors?
Yeah, as I mentioned previously, that Sestamib is indicated only in conditions of hypercalcemia and hyperparathyroidism. So if you don't have hypercalcemia, there is no need to do a MIBI at all, unless you document that hypercalcemia while on treatment. So anyways, you're going to monitor. So hypercalcemia with hyperpara is the only indication where you'll go for a Sestamib scan. So if you have a normocalcemia or low calcium, it rules out adenoma for all practical purposes, unless the patient is grossly calcium deficient or grossly vitamin D deficient, which you will anyways treat. So I think MIBI has a very selective role. You don't need to go by the PTH levels at all. You need to go by the calcium levels and decide based on that.
Okay, and are there any guidelines prior to starting SGLT2 inhibitors for evaluation of bone health?
No, I think unfortunately ISBMR has no specific guidelines for kidney disease, but CKD is a part of osteoporosis spectrum with a special condition, like you have steroid-induced osteoporosis. So there are certain indications where CKD should be separately looked into as a segment of osteoporosis disease. So I think the guidelines are common for all osteoporosis. They are more relevant to CKD. That is what I can say in this.
The question, I think they wanted to know about SGLT2 inhibitors and screening. With respect to, there's no specific, like SGLT2 inhibitor, we would be more cautious if somebody has a recurrent urinary tract infections. That is the one point, because as such, they are more predisposed to UTI. Otherwise, there is no specific checklist.
There is a data, Dr. Sahana, on canagliflozin and dapagliflozin worsening the fracture risk in CKD patients. So there are some papers which say so, but the risk benefit is again what you need to assess. So SGLT2 benefit to the kidney versus the risk of fracture. I think that is what decides whether you're going to use the SGLT2 in these patients or no. But I think the risk outweighs the benefits outweigh the risk much more. And this has been proven only with two SGLT2, that is DAPA and CANA. It has not been proven with EMPA. So we don't know whether it's a class effect or whether it is an isolated effect of these individual molecules. But I think that should not deter you, because you have a lot of therapies for osteoporosis. So you can definitely look into that and treat accordingly.
And also it was like canvas trial and another 2 trial
Yes.
only which specifically
Yes,
highlighted.
it
The
was
subsequent
very-
studies kind of clarified that the risk is not, I mean, the benefit would much outweigh the risk. So,
yes.
so as such, like, I mean, when it comes to checklist, it is not there, but of course it is individualized, and we should offer therapy if the patient is going to benefit out.
Yes, the signals regarding the fracture risk regarding the SLT2 inhibitors were subtle and they were not even confirmed. So I don't think we are concerned with the use of SLT2 inhibitors and bone health. I think the question was regarding like at what eGFR should we use and things like that. So I think in patients with with diabetes, we need to understand what we are using it for. If it is for an anti-hyperglycemic effect, then it would not be effective at a lower eGFR of, let's say, 45. But if it is a renal protection effect, as Dr. Gagan Priya had also pointed out, we can go very much down till the stage of dialysis. So I think we can use. So there are no hard screening criteria except Dr. Shahana has pointed out about we would avoid in somebody who has had a recent UTI or a repeated UTI, and I think that's the only one.
I think this was a very wonderful session. We have we have already exceeded our time limit, but it was so exciting and so wonderful and enlightening. Thank you all the panelists. It was very informative, and I personally have learned a lot of little nuggets of wisdom from all my nephrology and endocrinology colleagues. Thank you, Dr. Vaishali, Dr. Sahana, Dr. Namrata, Dr. Indira, and Dr. Kiranmai. Thank you, the organizers, Dr. Manjusha, and all others attending this meeting. I look forward to other such meetings, and thank you very much. Have a good evening.
Thank you. We thoroughly enjoyed your moderation, ma'am. Thank you.
Me too.
So much.
Me also. I also enjoyed the session very much.
Enjoyed thoroughly.
Thank you, ma'am.
Thank you.
Thank you very much.
Yeah, bye-bye. Good night.
Bye. Good night.
On
Dr.
behalf
Priya,
of on behalf of Women in Nephrology India, we thank you, the moderators, especially who have done a great job discussing the very pertinent topics for the day. And I thank all the panelists for an engaging discussion we had, and we truly enjoyed the discussion. Thank you so much. And we look forward to many such associations with Endocrinology Society of India. Thank you.
Thank you.